Good morning, good afternoon, and good evening. I hope you and your families are safe and healthy. My name is Diana Silver, and I'll be the moderator for today's webinar. I want to thank you for joining us. Before we get started, I want to provide you with some technical instructions. The webinar will be conducted in English with simultaneously translation to French and Spanish. And you can use the translation icon on the bottom of the screen to choose one of those languages. There are moderated discussions after each of the speakers' presentations, so you have an opportunity to ask questions of them. Please use the Q&A button on the bottom of your screen to submit questions, and be sure to include your city when you do. I also want to ask you to feed your questions into the Q&A right as they occur to you. You don't need to wait until the end of the presentations. Also, we will launch 2 polls during the webinar, so please respond to them. As I said, my name is Diana Silver, and I am a professor of public health policy at New York University's School of Global Public Health. I want to welcome you to the Bloomberg Philanthropies Partnership for Healthy Cities COVID-19 Global Leadership Series. This series of 60-minute webinars for city, COVID-19, and other health agency leaders is one of the resources Partnership for Healthy Cities is offering to its global network of 70 cities to boost their local response to this global crisis. The series is supported by Bloomberg Philanthropies in partnership with the World Health Organization and Vital Strategies. In a moment, we'll be joined by Dr. Santino Severoni at the World Health Organization, who will discuss strategies to protect migrants and homeless populations. Then, Dahlia Heller will discuss strategies to protect those who are incarcerated. We will next move to your questions for them. Then we will hear from Vicky Hobart, the head of health in the City of London, who will share her experiences in protecting vulnerable populations there. And she and our other speakers will take questions from you after that. We are particularly eager to hear about your experiences since you are joining us from over 40 cities around the world. The purpose of these webinars is to provide updates on the evolving COVID-19 science, expert briefings on responding to the pandemic, and opportunities for you to share your own city's experiences and challenges. The objective of today's webinar is to focus on innovative approaches to protecting vulnerable populations. Last week, we heard from experts about strategies to safely loosen physical distancing measures and examine some new resources for you to aid in your response. You noted that there are mental health issues that have emerged due to the physical distancing measures for adolescents, for seniors, and for others. You raised issues about domestic violence, the difficulty of making decisions to open schools, and the challenges of preparing the public to accept that some measures may need to be reimposed if outbreaks occur. The pandemic continues to be a worldwide crisis, with over 4 million cases and over 280,000 deaths worldwide. And while we can see that the curve is flattening in some parts of the world, new hotspots, where cases are doubling within 7 days, has opened in parts of Africa and in Asia. Meanwhile, cities remain critically affected by COVID-19, with new challenges emerging for local governments, particularly in how to protect the homeless, as in Toronto and in several Asian cities, and migrants, as you can see here in the headlines from Bogota. Cities are also contending with how to address a surge in domestic violence, as we heard here last week, and the fact that sex workers have been made more vulnerable during physical distancing interventions, as in Mexico City. And of course, those who are incarcerated are also at risk, as seen here in Chicago. Before we move on, we'd like to hear from you. So I'm going to release a poll asking you what your most pressing challenges are in protecting migrant and/or homeless populations in your city. While you take a moment to respond, let me introduce our first speaker. Dr. Santino Severoni, a physician, is the acting director of the Division of Health Systems and Public Health at the World Health Organization. Since 2013, Dr. Severoni has led the Public Health and Migration Program in the Division of Policy and Governance for Health and Wellbeing at WHO Europe. As a reminder, please put your questions into the Q&A function as they occur to you. You don't need to wait until the end of Dr. Severoni's presentation. Doctor?
Thank you, Diana. We can start the presentation. Next, please. With my short presentation, I would like to share some public health considerations to the fact of including or not including migrant and refugees at the moment of the COVID response. What are the challenges related to that, and what are the implications of the COVID-19 response for this population? When we are talking about migration health, we need to keep in mind that still we are talking about an issue which is high in the political agenda of many countries, but also is an issue which has remained very politically sensitive, often polarizing, and is an issue that mostly focuses on border control rather than on inclusion and having our national systems able to really include the newcomer in the country. Authorities, in order to manage or to control the borders, they tend to define these people. And the definitions and the related legal framework has a tremendous impact on then the level of accessibility to services, including health services, but also determining the level of entitlement for each of the persons which are hosted in the arrival country. Let's look to some of the challenges. Next, please. I can't see, yeah. The consequence of this situation is that usually all patients, all citizens, while they are try to access services in the international system, they have to confront with overcoming health system barriers, which are usually related to the ability to navigate and to get the best service for their needs. When we are overlapping the specific conditions and the legal frameworks and the consequent limitations that can be observed for migrants, those are the impact, those are the consequences that we are going to observe. The difficulty to overcome those barriers, the limitation due to the legal obstacles or legal limitation to access these services. The difficulty to understand their own rights and their own possibilities, but also the practical limitation due to their own language barriers or the availability of support to learn how to live and navigate in the system of an hosting countries. In addition, we need to remind that when a newcomer is arriving in one of our countries, tend to stratify, tend to adjust himself, tend to settle himself usually among the less privileged part of the population, with consequent elements related to the condition of living, sometimes quite deprivating, overcrowding, and with limited access to services. What are the effect of this? Please, next one. Well, the effect of this are pretty important. For this webinar, I wanted to bring you some solid recent examples taken from the reality in UK and in US, mostly because one of the main challenges is the insufficient availability of solid data that we can use in order to inform policy decisions and designing of healthcare services. In many countries, still is not a common use to collect data in disaggregated manner, not just in relation to gender and age, but also in terms of racial and ethnical group. In certain countries, we need to also recognize that this is forbidden by law and by constitutional elements. So this is really a major issue to deepen into the problem and to understand what's going on. We use the example of UK and US because in those countries, this disaggregated collection of data is actually a routine. And observing the development of the pandemic and the response to COVID-19 was quite interesting to see that despite there is nowadays a full commitment of government and health sector to address the best solutions to assist the national populations, in many cases there is also a level of no information or not awareness about the impact on minority, on migrants or refugees and asylum seekers. But actually we observed that in many cases, particularly the lockdown elements, which are extremely important component of the public health response, have been having a chain effect on the health outcomes of those populations. Interesting also to see that the policy decisions are usually taken at the national level, while services can be delegated at the lower level, a subnational. But actually the reality, the addressing of the most urgent and practical issues and challenges is usually responsibility of the community, of the mayor. And there is an issue of a gap between national, subnational and local level in terms of refining the interventions in order to have an inclusive type of approach. The direct consequence of our observations, or what we observe as a direct consequence of the situation, was that, for example, about 35% of the mortality among all cases observed in UK were basically happening among the refugees and migrant groups or ethnical minorities. Similar interestment, the contagion of population in UK was basically about 35% interesting the same community out of the overall population interested. We went to look also to data collected in city of Chicago, where we observed that about 50%, 52% of the mortality observed was among the African American population, despite this population representing only the 30% of the local population. So those elements are quite concerned and bringing very clearly to us the question, what are the causes, why that is happening? Well, in these slides you can see that basically the first element is related to governance, is related to the fact that we are living in countries where, and this is something not new, that we all know very well, where the element of inequity, of disparities is now a structural element of our societies, and the COVID response situation in many cases has been determining a sharpening of those inequalities for a number of reasons. I would differentiate the reasons into three main ones. Environmental and social reasons, which are an important trigger for increased risk of communicable and chronic diseases, biological factors or biological explanations, and then the last element, as I mentioned, is an element related to governance. Okay, let's look at the environmental and social conditions. For the reason I mentioned before, we are observing that usually first comers, migrants, refugees, when they are integrating in our society, they tend to also go for jobs, the most available, which are usually jobs with a higher risk of health type of considerations, or they are tending to fill jobs which during the COVID resulted to be frontline jobs. We all know how important is the migration of human resources for health worldwide and the shortage of nurses and doctors worldwide. So today, migrants, healthcare workers are playing a very important role in our health sectors and health systems, and in fact, put those people also at the front line together with their own national colleagues with an increased risk of contracting COVID-19. But also those involved into transport, retail, business. So those are all activities which kept going on even during the lockdown in order to ensure essential services and functioning of our society. And this has been, of course, determining a quite important increase of risk for disease. But also the situation is structurally an issue of determining an increased risk for communicable disease and chronic disease for those populations, especially if this is linked to a difficult or reduced possibility of accessing to preventive services or curative service by our health systems. Then we have the biological explanation. We all know we have solid evidence that there is a variation of prevalence of certain diseases related to genetic factors, but also related to life course issues. So by living in a certain lifestyle, we can trigger or not trigger the increased risk of contracting certain communicable diseases or non-communicable diseases. And there are scientific evidence and facts showing that, for example, certain ethnic groups, they are more prone to be affected by diabetes, for example. So all those elements, especially in a situation of COVID response, where the underlying health conditions, they play such important role for mortality and morbidity of patients infected by COVID virus, by coronavirus. This has been playing probably a very important role, contributing together with the factors I mentioned before to the increase or a quite important mortality and morbidity among this population. Last but not least is the element of governance. As I mentioned, the element of governance is central because the designing of the health systems in our countries is usually designed thinking to a national population. The diversity of population, especially when this is manifesting in a short period of time with the arrival of substantial number of newcomers, migrants, refugees, asylum seekers, pose some issues of rigidity and capacity to have an inclusive attitude or the health system flexibility and responsiveness able to really capture the need of the entire population. And the COVID experience, COVID-19 response experience show to us how important it is not to leave anybody out of our public health efforts. Every time we are underserving a community or a part of the population, we are basically losing a battle towards the defeat of the COVID-19 pandemic response. Next, please. So what should we do to address those things? Well, in reality, this is not rocket science. Most of the actions needed are well known, and they need to, as I mentioned up to now, be able to meet the need related to a decent and safe and healthy life condition, lifestyle, and also services, availability of services, flexibility and sensitiveness of the health systems able to serve and to assist all population. in the spirit that we like to recommend as a WHO of the universal health coverage, means that the legal framework, the administrative definition of a migrant, regular or irregular, or refugees or asylum seeker, supposed to not be sufficient valid reasons to prevent access to our health systems. And this is particularly true when we are referring to preventive measures. So if we look at the slides, as you see, there are pretty bold recommendations, because providing decent housing and living condition is probably one of the most important elements. And at the time of COVID, we've been paying so much attention, recommending to our populations to really implement basic norm of personal hygiene and physical distanciation. And in many cases, we need to recognize that the living conditions of those population, of those group of population in our society, actually not even allowed to implement such public health measures to be so important for the response to the pandemic. But also sufficient information in terms of language, in terms of regulations, norms, in order to facilitate access and navigation of the health system at country level. The necessity to have a policy process which is able to capture the need of the entire population. So to include the element of migration and refugees health into the process of policy designing and service provision to our population. What I'm saying probably sounds pretty obvious, but in reality is not. And this is an object of continuous discussion and negotiation, because for the political sensitiveness around these topics tend to prevail always the discussion on the economic implications. Are we going to be able to pay service for everybody? So probably we're supposed to stratify our populations among those which they are entitled, those which have the right, and those which have the papers, they are nationals, rather than to open to everybody. In reality, this is a really risky and from the public health point of view, not payback type of approach. But also it's important to...
Doctor, we will have to move on quickly, so I ask you if you could just wrap up. Thanks so much.
I'm wrapping up with the next slides. So here is the practical example where the political decision had been playing a very important role in mitigating the problems and the impact of non-acting in the right way. We have the case of Portugal, where the government decided to provide temporary residency to everybody, including the irregular migrants. And this has been immediately facilitating access to service. Or the case of Buenos Aires and New York, where was also, in terms of surge capacity, offered the possibility to migrant healthcare workers to be included in this system in order to contribute, participate to the response measure. Thank you very much.
Thank you so much, Santino, and I'm sorry I had to interrupt.
No, thank you.
Before we move on, I'd like to release our first poll responses now. And as you can see, about 41% of you said that the most challenging issue for you in protecting migrants or homeless populations is in providing essential daily living resources. Another 41% of you indicated that migrant and homeless populations' ability to comply with physical distancing measures was the most challenging issue. While 9% of you indicated that ensuring access to adequate hygiene or addressing stigmatization were the main problems. As you can see, Santino, these are the results. Maybe when we come back in the Q&A, we'll talk about them. So in preparation for our next speaker, we now want to ask you to respond to our next poll. Our poll asks you, what is the most pressing issue for your city in protecting those who are incarcerated? While you take a moment to answer this poll, let me introduce our next speaker. Dalia Heller is the Director of Drug Policy Initiatives at Vital Strategies. She has more than 20 years experience in drug policy and harm reduction efforts, and has served as an assistant commissioner for the Bureau of Alcohol Use and Drug Prevention Care and Treatment at New York City's Department of Health. Dalia?
Thank you, Diana, and greetings, everyone. I'm grateful for this opportunity to speak with you about incarceration and the opportunity for decarceration to protect people who are vulnerable to COVID in this outbreak. I'm going to discuss briefly what is the risk we recognize for COVID-19 infection and transmission in detention settings, what we've seen happen in the US and around the world with COVID-19 outbreaks in prisons and jails, how we recognize the need for decarceration in this experience, and what are some opportunities and considerations for cities to implement decarceration strategies. Next. So I think quite obviously we can recognize that the greatest risk for COVID-19 for people in prisons and jails is overcrowding. Importantly, we know that prisons or jails are not developed or designed with health in mind as a primary structural feature. Rather, security is the structural feature that is emphasized in the construction of these settings. And so there is not often an emphasis on health. We don't see sufficient health care in many prisons and jails. It is not necessarily a standard of care or of service in these settings, nor do we see sufficient sanitation, ventilation, etc. So we could recognize that for people who are incarcerated, there's really not an emphasis on their rights as individuals to protection, especially in the face now of a highly infectious disease. Next. There was has been early recognition by public health authorities, both in the US with the CDC and from the WHO Europe, on the risk created by detention settings for COVID-19 infection and transmission. Next. And in the US, we've seen growing evidence of COVID-19 outbreaks. A survey, I think important to highlight, of state prisons across the country found an average rate of COVID infection among prisoners that was 3.5 times greater than the rate of infection in the general population. In New York City, we saw that the rate of infection was 4 times similar rate 4 times higher than the rate of the surrounding city where the jail Rikers Island is located. And to note, New York City is one of the hardest hit areas in the world for COVID. So we see this extraordinarily heightened prevalence and risk of these settings. Next slide. I think this is quite a striking finding. What we've seen already happen in the US are the largest COVID-19 outbreaks are concentrated in prisons and jails. So if this doesn't show us that this is a serious health problem, a serious setting of infection, it's hard to know what might show us that. Highlighted here at the top is the largest COVID-19 outbreak we've seen in a congregate setting at the Marion Correctional Institution, 2,439 cases at the time that this information was compiled. So quite remarkable. Next slide. Similarly, around the world, I think we've seen growing recognition of the risk posed by detention settings to people who are incarcerated there, and I think quite importantly also to note that the people who work in jails and prisons are also at risk. So where we might consider that there is resistance from officers or folks working in law enforcement to considering an alternative to incarceration in this time, recognizing the great risk that people who work in these settings also face may be a useful advocacy tool in proposing alternate strategies to incarceration. In Iran, early on, they freed about 1/3 of the incarcerated in the country temporarily. However, in Brazil, there were recommendations early on for release, but this guidance has not been accepted. And this is just an overview of what we've seen as a lot of movement, but not in any uniform or standardized way in countries around the world to release the incarcerated, at least temporarily, as a COVID protection measure. Next slide. So I think it goes without saying that we can recognize prison contagion of COVID-19 is a global problem. Next slide. When we talk about decarceration as a strategy, then what do we mean? So this term decarceration is, I think, newer in our language. It's not recognized even by some of our computer software as a word, if it is a word, and it is a word that really means reducing incarceration. So moving away from incarceration to decarcerate. So how can we do this? As I've noted, releasing people from prisons and jails is very simply our solution by reducing crowding in congregate settings. But importantly, with that release, there is also an importance to focus on re-entry because people are leaving a congregate setting where they may have been exposed and moving into communities where there may also be exposure. So we have to ensure that people are protected upon re-entry into the community from release. And then finally, we can actually reduce incarceration by reducing the front end, reducing arrests that result in incarceration, to reduce both custodial exposure when an arrest is carried out by an officer with an individual, and congregate exposure with incarceration. Next. There is emerging consensus on the need for decarceration as part of a COVID-19 response. We have seen widespread advocacy since the early days. Here in the US, it's been a great focal point for many social justice groups. We've seen peer-reviewed health literature develop on COVID-19 and incarceration with papers in many journals, including The Lancet, BMJ, JAMA. We've seen unrest in prisons around the globe, especially in response to what has been measures that have increased risk in many places, including lockdowns, prevention of family visits to prisoners, and a lack of releases. And finally, back in March, we saw human rights declarations coming from some of our normative bodies, including the European Committee for the Prevention of Torture and Inhuman or Degrading Treatment or Punishment, and the UN Office on Drugs and Crime. Next. Just last week, the UN Office of the High Commissioner on Human Rights released this statement, which I think is quite important because as we've seen releases happen in states, there has been a focus initially on those who may be most vulnerable to COVID-19 infection, including older populations, people with underlying medical conditions, etc. However, this statement makes the point that broader measures are needed because the real problem in these settings is overcrowding, and that many prisoners could well be released without so-called risk to society. We incarcerate many people around the world for non-violent crimes. We incarcerate young people, children who are, developmentally perhaps not appropriate for incarceration to begin with. And to reference Dr. Severoni's presentation, we recognize also we have significant detention of people who are migrants or refugees into countries. So people being held on immigration offenses are at enormous risk as well. Next slide. When we talk about decarceration, we have to bring social equity analysis to our decision making, who is released and how. because who has been incarcerated is really has been shaped enormously in the US and I think around the world. We see by racial and ethnic groupings. In the US, we see that Black people are disproportionately incarcerated in this country and also have much higher rates of COVID-19 as illness, especially severity of illness and death. This is an example of how racism shows up across our structures, and as COVID-19 has exposed the social or structural inequalities inherent in our systems. So it is important that these issues are addressed head-on in decisions to decarcerate. How are we looking at data? How do we understand who is incarcerated? And how are we using that data to proportionately release in a way that is going to promote equity? And how are we ensuring safe release? Because release alone in this environment is not sufficient, but we are obligated to protect people, as Dr. Severoni has noted. Next. Correctional health is community health. People move in and out of incarceration, so it is our obligation to recognize that those who are incarcerated are part of our society and are part of the community. We can therefore consider decarceration by reducing arrests, as I've noted, reducing overcrowding, and considering really in this process of release, how do we take advantage of the opportunity now to consider broader criteria to immediately release people? Next. And re-entry is really key, as I said, to ensure that there is a safe process of decarceration, both for the individual incarcerated and for the community they are being released to, families, etc. So ensuring housing is key, as Dr. Severoni noted as well, ensuring access to support, public benefits, or ensuring that there is access to clinical and social service, and ensuring that people have essential supplies. In the US, we have an enormous problem with overdose upon release, which, as we've had releases happen from jail in the face of COVID, we've also had spikes in overdose because of that release, which is a great risk time for people who use drugs. So providing medications such as naloxone. Importantly, also for people under community supervision, such as parole, probation, halting in-person reporting requirements is a protection both for the individual and the officer. People should not have to travel to report because they're involved in community corrections. Next. This is an opportunity, and as these changes are happening now, it's also an opportunity to consider systemic reforms that can sustain these reductions. Overcrowding in jails and prisons is a health problem. It's also a social problem. And if we reduce arrests, we can reduce overcrowding. There's strategies for reductions, including changing some criminal offenses to civil offenses so they do not result in incarceration. It's also an opportunity to divert people to support and services, which we recognize may actually be what people need rather than incarceration and punishment. And to sustain reductions in incarceration, we can consider what are the alternatives to incarceration. We can stop holding people before trial. There's been an enormous problem in the US. So people are held without a sentence. And we can also address how long people are incarcerated for, sentencing, etc. And ensure in all of this that we develop and establish a robust re-entry infrastructure to sustain decarceration and protect people as they return to the community. Thank you. Next.
Thanks so much for your presentation, Dalia. I want to just give you the results of our second poll, which will be unsurprising to you. 85% of those responding indicated that the most challenging issue for them is overcrowding in facilities. We're actually running over, so I think what we're going to do at this point would be to move on to our next speaker and then have you all participate in the Q&A at the end, because we do have some really interesting questions that I hope that you'll be able to have a chance to address. So let me move on now, and we're going to move to our city spotlight and focus on some of the efforts that you're undertaking. We're going to hear from Vicky Hobart. Vicky has served as the head of health for the City of London for the past 2 years. Prior to that position, she was chair of the Association of Directors of Public Health for London and has served in many other roles in the UK and elsewhere. Vicky, let's go to you.
Thank you and welcome everybody. So my role is as Deputy Statutory Health Advisor to the Mayor of London, Sadiq Khan, and the wider Greater London Authority, which includes functions on transport and police and crime. And I was going to talk about very briefly the overall approach to COVID in the city and then pick up specifically some work that's been championed by the Mayor on prevention and control efforts with communities that are rough sleeping in London. Next. So as of 10th of May in London, we had about 25,000 labbed confirmed cases of COVID and had lost around 5,000 Londoners. And there's been a lot of work ongoing around expansion to testing and reporting of the progression of the epidemic in London. A large additional hospital facility was mobilised, which thankfully we haven't needed, which was expanding access to critical care in the capital. And we're reasonably confident at the moment that we've reached the peak in terms of both cases and deaths, which are thankfully the doubling rate is increasing, and we seem to be coming out of the other side. A few lockdown measures are being lifted in England this week. I'll touch on that in a minute. However, there are still significant ongoing concerns around cases and outbreaks in certain settings, including in care homes and some health and care settings. And although we're relatively early in the epidemic, what we have seen is some significant variation between local authorities. So some of the local government jurisdictions in London, we have 33 local authorities in London. We've got some fairly significant variation in mortality rates between local authorities and a real inequality in impact on different population groups. Next. So the types of issues we've been considering. So the backdrop to COVID for us in London was the fact that we had a London Health and Equality strategy. The Mayor, this is a statutory requirement of the Mayor of London, and Sadiq Khan has championed a fairly simple strategic framework under which sits a lot of detail and complexity that reflects the global city. And the strategy focuses on children, young people, parity in mental health and physical health, the places people live, the communities they thrive in, and health behaviours or ability for healthy living. And that really set the backdrop for the work on COVID in the city. We'd also developed a vision for Health and Care London, which was really providing some direction on how the health and care system work together to improve population health in the city. And some of the issues that COVID has thrown up for the city include, as we've heard already, issues around exposure, particularly for key workers. And I'd call out concerns at the moment around bus drivers, taxi drivers in particular. Issues around the underlying risk and the distribution of that risk between populations around underlying illness and comorbidity. Disproportionate impacts on Black, Asian and minority ethnic communities that colleagues have referred to already. Issues for vulnerable households, particularly in relation to child poverty, food poverty and domestic violence. Concerns about emerging issues of loss of work and income, fragile housing and overcrowding in London, and changes in the social support that individuals and families can access. We've also got evidence that some groups have struggled to adhere to the public health advice for a range of reasons relating to housing, financial insecurity and dependency on support. And we knew that in London, and we knew that from a lot of work that had gone on in the health and equality strategy and wider partnership work, that would include the homeless population and adults in residential settings, overcrowded housing and undocumented migrants. Next. So we're just at the phase in England when we've moved to a second phase of the plan. So we've moved from stay at home, protect the NHS, save lives, to, in England, a key message of stay alert, control the virus and save lives. And we would recognise that there has been some deviation in that between England, Ireland, Scotland and Wales in that key message. And from the context of London as a global city, we're part of the English kind of public health system. So the key measures in the UK context have been social distancing or physical distancing as it's described in other countries, clear guidance around safe isolation in the event of exposure or symptoms, some identification of a population who are shielded, and that's based on clinical risk, and our primary care colleagues have identified those individuals and they've been written to and encouraged to isolate for 12 weeks, but also identification of other significantly vulnerable populations who've also been advised to take precautions. There's been systems around welfare and furloughing of staff, so state support for those companies that have had to close down temporarily. Schools have stayed open, but for a much limited number of children. So the children of key workers, essential workers, as colleagues have described, and those children that were identified as vulnerable. And then finally, there's a lot of effort at the moment in the UK around mobilising testing and contact tracing plans. Next. So I mentioned the fact that this was building on some work in London around a vision for health inequalities and a vision for how the health and care system works together. We also have a life off the streets strategy that the Mayor has championed and developed, which has been about trying to make some long-term change for the lives of rough sleepers in London. I put some key information there on the slide deck around the average age of death for that population, the range of nationalities that are represented amongst our rough sleepers. We have fairly good ways of identifying the numbers of people that are seen sleeping rough on London streets. We also know this is part of a wider population of the hidden homeless. So we often refer to the term of sofa surfing. So these may be often younger people who may be staying temporarily with family, with friends, maybe sleeping rough occasionally, moving out of through a whole range of transitionary housing arrangements. We've seen an increase in the number of rough sleepers over the past 10 years, and we have very good data collected from the NHS over many years around hospital admission, hospital attendances, and use of primary care to build on. So there was a fairly good understanding of this cohort. There was political commitment through the Life Off the Street strategy, and we also had a health and care vision in place around the need to make a difference to the health outcomes for this group. Next. So building on that, I guess COVID provided, in a way, a springboard for action, much, much more rapid action from a set of partnership conversations that had been happening in the city about all that we knew about this population and how we could then actually apply that at speed to the public health emergency that we were faced with. And what emerged out of that was a partnership between the Greater London Authority and the Mayor's work on Life Off the Streets, local government, so the 33 authorities I've referred to, the National Health Service, particularly with a view to issues around hospital admission, the ability to safely care for people with COVID in hospital, and the need to facilitate safe discharge from hospital as soon as possible. A partnership that included social care colleagues. So we have the social care system that is based in local government, but also works with a whole range of independent providers, and mental health services, particularly concerned with mental capacity. And the model that emerged with good clinical engagement was in essence, a fairly simple cohorting model. And what we did was work with the GLA and local government as the organisations responsible for assessment for housing and provision of accommodation, with the voluntary sector to effectively cohort rough sleepers that may have been in touch with a range of services, whether they were outreach services, existing hostels, day opportunities, food banks, etc., to basically encourage people into 3 forms of accommodation. So for those that were symptomatic, we recognised very early on they would need somewhere to be cared for, so COVID care provision was identified. That would facilitate both hospital discharge, but also rapid access into accommodation for those experiencing symptoms. So a COVID care, a hotel was basically purposed for that purpose, a COVID care facility with bathroom facilities, etc. The second cohort was for those that were asymptomatic but potentially at increased risk of severe illness from COVID. So effectively the equivalent of the kind of shielded group. And lots of effort went into there to the kind of assessment and triage process for that cohort. And again, this was recognizing that those individuals, based on data we had from a number of health and care systems, their health status, although they may be relatively young, may potentially be that of a much, much older person with significant comorbidities, etc. So that was the second cohort. And then the third cohort was working with local government and GLA and existing accommodation for those at less risk of severe illness from COVID to ensure that they could be signposted into that accommodation. Next slide. What was put in place in that cohorting model was the importance of testing, both for testing for people entering into that accommodation and also surveillance testing to monitor the risk of cases and outbreaks, with an understanding of the needs of people living in each type of accommodation and with the ability to pick up symptoms very early. The outbreak management response was developed very closely between the housing providers, with a real effort to make sure that individuals were registered with primary care so that they were put in touch with general practice, and a robust kind of assessment was put in place where that was required. We also mobilised some peripatetic drugs and alcohol support through a commission service to work with those individuals and facilities on drug and alcohol needs, and worked very closely with some of the voluntary sector organisations that were offering outreach and kind of day opportunities that had relationships with many of these individuals to explain the process, to introduce them to the accommodation, to encourage them to register with a GP, etc., etc. And there was some prioritisation of that accommodation within it around use of single rooms and bathrooms where they weren't available to all. The coordination of that came from the GLA, again, as a springboard from the Life Off the Streets forum. And what we did was very rapidly work through with a clinical advisory group for London, the clinical and care pathways that were going to be required to support these individuals. So as I've described, looking at primary care, looking at mental health, looking at drugs and alcohol. Next. So initial data has been positive in the sense that we haven't seen any large outbreaks in any of this provision. We've moved a significant number of people off the streets, over 1,000. And the focus really, from the perspective of coming out of this initial peak and looking at an initial releasing of lockdown measures, is balancing, well, how can we build on this good progress for those individuals? So we're currently undertaking a needs assessment, a health needs assessment with this cohort to start to plan what the next steps would be for those individuals. It has been quite a life-changing experience for some. And for others, there are, as you'd expect, very, very severe and enduring health and care needs to be addressed. So that work is in train, working with the existing cohort. We are also mindful that we have seen new people emerging on the streets, and in the context of economic pressures and downturn, and as part of the lifting of measures and planning for wider impacts, we're also mindful of the need to work with what could potentially be a newer cohort of rough sleepers coming to the streets of London. Finally, just to say the next steps for us is, as I said, the needs assessment work, but also the need to relook at governance arrangements and resourcing in this next phase of how to sustain for most of these people into existing services, and for emerging needs or new needs, how we will have that conversation in London around the resourcing governance of those that next phase of decision making. Thank you.
Wonderful. Thanks so much, Vicki, for your terrific presentation. We're going to move on to questions for everybody. And actually, our first question, Vicki, is for you. And the question is really about addressing overcrowding and high density in cities that make some of the physical distancing measures that we would like to see put in place feasible. And just a question about whether or not you have any guidance to offer in addressing those problems. Particularly, I think our question is from somebody at a city in India, and I can't remember which one, but sorry.
Well, yes, I would reiterate clearly from a public health perspective how important that is. From a UK context and a London context, I suppose we are interested, particularly as we reintroduce contact tracing. What will the public health advice be to individuals that are potential contacts in the context of their own households? So we've seen the need to focus on care homes, absolutely. We've talked about people that are incarcerated. I know that we've done lots of work in the UK, in London in particular, on things like refugees, houses of multiple occupation. And there's discussion at the moment about the different ways in which you can support both the individual and the household, but also other parts of the system involved in housing decisions in supporting them in that. So that could be through landlords in the case of houses of multiple occupation, where you're looking at shared bathroom or kitchen facilities, yeah, and whether they're adequate. Mm-hmm. Local government plays a role in that as well. The ability to mobilise hotel accommodation for rough sleepers to get them off the streets, enable them to recover if they were infectious and to reduce the risk of infection, means that for a number of cities, if we're taking it really seriously in terms of suppressing the virus, we may well need alternative flexible accommodation options for those that are challenged to self-isolate. And I think a number of cities are going to be working through within their context, how do you do that in your city? How could you make accommodation available for those that are symptomatic, even if it's on a relatively short-term basis?
Great, thank you so much. Our next question is for you, Santino. Truck drivers are temporary migrants as well, and our attendee says, for the moment, hundreds of truck drivers are stuck at various borders, for instance, between Uganda and Kenya, and forced to wait in line to be tested, etc. The situation is critical, and they wonder if you have guidance to offer here about how to address this issue.
Well, indeed, situation poorly managed where there is a possibility of leading into overcrowding or lack of basic hygienes or distanciation measure are a source of major concern. And indeed, we have past experiences of those situations leading into expanding the spreading of epidemic, of outbreaks. So indeed, the recommendations are pretty the same in terms of promoting the essential physical distanciation and preventive measures. And those are very well stated in the clear technical guidance that the colleagues of emergency, they are producing since the beginning of the pandemic response. So basically, there is no, I would say there is nothing new in terms of enforcing those requirements, those conditions which are creating a condition of safety for truck drivers standing at the border.
Great.
We have been similar concern, if may I add, for actually camps in different parts of the world hosting refugees and migrants, where despite the clear instructions and recommendations to the health sector of all countries, in many cases we are observing that this doesn't include also those contexts. So indeed, this is a very important flagging up and should be addressed with authorities.
Thank you so much. I want to thank all of our panelists for answering those questions. Unfortunately, we're out of time. So I want to close our webinar by letting you know that if you didn't get your question answered, we'll be following up with you directly. After this webinar, we'll be sending you the slides for you to adapt as you like. And in addition, I want to draw your attention to the resources available at citiesforhealth.org, especially those on protecting vulnerable populations. Last, I'd like to thank Bloomberg Philanthropies, the World Health Organization, Vital Strategies, and the Partnership for Healthy Cities for making this webinar possible. I would also like to thank our speakers for their stellar presentations. And last, I'd like to thank all of you for attending. Have a safe and healthy week.